Welcome. We are discussing drug distribution. And when you come to drug distribution, the plasma protein binding of drugs is a very important issue. Some drugs have got a capacity to get bound to the plasma proteins. And the bound form of a drug remains inactive, whereas the free form circulating in the blood is the active form. And there's a constant turnover between the bound and the free form. As the free form gets utilized, more and more drug is released from the bound form. So it's a dynamic turnover. Naturally, the drug which has got high plasma protein binding activity is likely to have a longer half-life and longer duration of action. Plasma protein binding of drugs, PPB. The drugs get bound to two kinds of proteins in the plasma. One is albumin, to which mostly acidic drugs get bound, and the second one is alpha-1 acid glycoprotein, to which the basic drugs most probably get bound. Here's a list for you. The first column shows the drugs which mainly get bound to albumin, and they are acidic drugs. These include NSAIDs, non-steroidal anti-inflammatory drugs, sulfonamides, tolbutamide, warfarin, barbiturates, valproate, benzodiazepines, phenytoin, so on and so forth. The second column is about the drugs which get bound mostly to alpha-1 acid glycoprotein, and these are mostly basic drugs like beta blockers, verapamil, quinidine, disopyramide, lidocaine, bupivacaine, so on and so forth. Now let's look at the implication. What happens? There are two drugs, A and B, and both of them have got same kind of affinity for the plasma protein binding sites. Suppose B is already bound to the plasma protein, A comes and displaces some amount of B. So what's going to happen is free concentration of drug B is going to be more in the blood. And this is something which is unaccounted, which you never imagined. You had given treatment only with drug B to the patient. Another physician added drug A. Drug A displaced drug B from the plasma protein binding sites, and the drug B started producing more effect. And this more effect could be toxicity of the drug B. This is the implication of the displacement from the plasma protein binding site and leads to very important drug interactions. Let's imagine, for example, a patient is receiving an oral anti-diabetic drug called tolbutamide for diabetes mellitus. And this patient gets some pain, some inflammation, some swelling, and gets an NSAID, a non-steroidal anti-inflammatory drug. This NSAID is likely to displace tolbutamide. It's an oral hypoglycemic agent. It's supposed to decrease the blood sugar, and this patient's blood sugar will come down, which you never had imagined. This could happen. And the effect will be severe hypoglycemia. Another example is about warfarin, which is an anticoagulant. This is highly plasma protein binding. To this, if you give a drug called phenytoin, phenytoin is likely to displace warfarin, and there will be excess anticoagulation, which ultimately means bleeding. So such kind of drug interactions can happen due to plasma protein binding displacement, and you need to know the drugs which are highly plasma protein binding. So also, if the patient suffers from hypoalbuminemia, then there can be more concentration of the free drug because there is no albumin available for the plasma protein binding. This matters for those drugs which are more toxic like phenytoin and digitoxin. In general, the plasma protein binding is more important for those drugs which bind to albumin. Let's come to the issue called as redistribution. This is very funny. This happens in case of some drugs. For example, they are highly lipid soluble. They enter the central nervous system very rapidly, produce a rapid effect. Not only this, they also come out of the central nervous system very rapidly. That's why we call it rapid redistribution, and their action gets over. So these drugs produce a very rapid effect, very rapid onset of action, and a very short duration of action because the drug is coming out of the central nervous system. And this is true about great thiopentone sodium, which is used for induction of anesthesia. It produces a very rapid induction, and the anesthesia lasts for short duration. Another agent doing the same thing, rapid redistribution, is propofol. On the other hand, there are some drugs which have got a slow redistribution. For example, there is lorazepam from benzodiazepines. It goes inside the central nervous system and comes out of the CNS very slowly. And because it comes out very slowly, stays there over a long period of time, and this is why in some situations for the sustained effect, lorazepam is preferred. So that's a kind of slow redistribution. I think we already discussed the formula. Half-life is equal to 0.693 multiplied by volume of distribution divided by clearance. And what is clearance? What is elimination? Is the rate of elimination divided by the plasma concentration. Let's come to elimination kinetics now. How the drugs get eliminated. We have two types of kinetics. The first one is called first order kinetics or linear kinetics. In this, a fixed proportion, fraction or percentage of drug gets excreted. So the rate of elimination remains directly proportional to the plasma concentration. Whereas in zero order kinetics, which is called non-linear kinetics, a fixed quantity or amount of the drug is excreted, irrespective of whatever is plasma concentration. This is also called saturation kinetics. And when does this happen? When you start giving a drug in higher and higher dosages, the capacity of the body to metabolize the drug goes on getting exhausted. And then the body says, I'm going to eliminate a fixed amount of drug. And this is why the drug goes on accumulating in the body, and this is the implication of zero order or saturation kinetics. Let's look at the slide and see what is this first order kinetics. Suppose the concentration is 100, the excreted amount is 10, the remaining amount will be 90. If we make the dose 200, excreted will be 20, because it's a fixed proportion or fixed percentage. So we derive from this, it's about 10% of the drug is getting excreted. So out of 200, 20 gets excreted, 180 remains inside the body. When the dose is 300, 30 will get excreted, 270 remains. When the dose is 400, 40 gets excreted, 360 remains. This is first order. Let's have a look at zero order. What happens? Concentration is 100, excreted 10, so 10% excreted, 90 is remaining. But after this, probably the body is not able to metabolize the drug. And this is why when you make the dose 200, still the body says, I'll excrete only 10. So that's the fixed amount, not the percentage. So 10 gets excreted, 190 remains. 300, only 10 gets excreted, 290 remains. 400, only 10 gets excreted, and 390 remains. Whereas, if it would be first order kinetics, out of 400, 40 would have got excreted, and the concentration would have been 360. At higher levels, this difference between 360 and 390 is a great difference, and it leads to very severe toxicity for those drugs who produce zero order kinetics. Most of the drugs follow the first order kinetics. And if you give them in a very large dose, of course they'll move to zero order kinetics. But most of the time, within the therapeutic range, they follow first order kinetics. And this is very good because you can predict the effect. Because you know how much is going to remain and how much is going to get excreted, because it's a fixed percentage. Whereas some drugs follow zero order kinetics. And we need to remember them. The first one, very important, is ethyl alcohol. Then the anti-epileptic drug phenytoin, anti-diabetic tolbutamide, an anticoagulant warfarin, and theophylline. Also salicylates, they start following zero order kinetics at higher dose level. So what happens is a small increase in the dose leads to unpredictably high concentration and severe adverse effects. This is why these drugs have got less safety or less therapeutic margin. So first order and zero order. Let's have a look at the graph. I call the first order kinetics, which is the blue line here, as linear kinetics because it is a fixed proportion or percentage of the drug gets excreted. Whereas the red line is indicating zero order kinetics And what you can see is as you go on increasing the dose, after a certain dose level, the graph suddenly takes a very steep slope and it goes high up. That's indicating that after a certain dose, a fixed amount of the drug is getting excreted and all the rest of the drug goes on accumulating in the blood, leading to very severe adverse effects or toxic effects. Here are some kinetic relations which might be useful to you. You can visualize on this slide. The dose is decided by the target plasma concentration multiplied by clearance divided by bioavailability. This especially is important when you talk about oral route of administration because the bioavailability is much less by oral route. Whereas if you go to the intravenous route of administration, the bioavailability is 100%, so there's no need of denominator. So there's no denominator for the second and the third formula. There's no question of bioavailability is 100%. So there's no problem about bioavailability, and what you have to worry only about is the volume of distribution and clearance. For continuous intravenous infusion, the maintenance dose is decided by the target plasma concentration multiplied by clearance. Because it's the maintenance dose, how much is going out is very important. But as far as loading dose is concerned, it's a loading dose. You also have to saturate all the sites where the drug is going to go, and that's why loading dose is target plasma concentration multiplied by just volume of distribution. It means how much drug gets distributed is going to decide the loading dose. What is therapeutic drug monitoring? TDM. Yes, we are discussing about various drugs which could be dangerous, which could be toxic due to the zero order kinetics, and this is why there are a few drugs for which monitoring plasma concentration is of value. So if your patient is receiving these drugs, it's very important to monitor what's the plasma level of the drug. There are some examples. One is digoxin, used for heart failure, anticonvulsants and antiarrhythmic agents, theophylline, sometimes aminoglycoside, lithium, which is used for bipolar disorder, tacrolimus and cyclosporin. So also, monitoring the drug concentration becomes important when the patient is suffering from renal failure, when the patient is suffering from some poisoning, or when you are giving the treatment and you are not seeing an adequate response in the patient. It's good to go to the blood, to the plasma, and check what's the plasma level of the drug to know if really the patient is consuming the drug and whether really the drug is appearing in the plasma or no. Sometimes the patients don't take treatment. You can also check compliance with the help of therapeutic drug monitoring. Now we're going to see what are the methods of prolonging the duration of action of a drug. By simple logic, you can think of prolonging the absorption of drugs, and for this you can prepare sustained release capsules or tablets, which are called SR tablets or capsules or spanules. As far as parenteral route of administration is concerned, you can inject a drug with a binding agent which is going to keep the drug together in a bound form and is going to slowly release the drug, so you get a longer duration of action, or inject the drug in insoluble form or oily solution, or give pellets or cyalastic or biodegradable implants which will release the drug slowly, or a very common example in practice is you inject a local anesthetic, lidocaine, with epinephrine. Epinephrine will constrict the blood vessels and will decrease the rate of entry of the local anesthetic. So also the transdermal therapeutic systems, they will deliver the drug slowly. Or try to prepare the congeners of the original drug which have got a high PPB, that's plasma protein binding, which we just saw. And because the drug is highly plasma protein binding, is going to have a long duration of action. Or you can retard the rate of metabolism, decrease the rate of metabolism. For example, cilastatin can decrease the rate of metabolism, breakdown of imipenem, or ritonavir can inhibit the metabolism of other anti-HIV drugs, and this is why you can get a better action of those anti-HIV drugs. Or you can decrease the elimination or excretion of a drug by using a substance probenecid with penicillin, because probenecid will compete for the renal excretion of penicillin, and penicillin will be reabsorbed and you will have a longer duration of action of penicillin. So that's about the methods of prolonging the duration of action. Let's discuss what's biotransformation. It's a chemical modification or alteration in a drug, and the purpose of biotransformation finally is to make the drug easily excretable so that the kidneys can handle the drug properly and they can eliminate. In general, non-polar drugs will become polar, lipid-soluble drugs will become less lipid-soluble, and non-ionized substances will become more ionized, so that the renal tubules won't be able to reabsorb the substance. Biotransformation serves an important purpose of detoxification, but occasionally a toxic metabolite may be formed. The sites for biotransformation include liver, kidneys, intestines, and sometimes lungs, plasma, and other tissues. The enzymes which produce biotransformation, carry out biotransformation, may be microsomal or non-microsomal. The microsomal enzymes are located on the smooth endoplasmic reticulum of the microsomes, and this is called cytochrome P450 dependent enzyme system or mixed function oxidase system. This carries various subfamilies. The most important one is CYP3A4. Still many more families exist which include CYP2D6, CYP1A2, CYP2C9, and CYP2C19. This microsomal enzyme system can be easily influenced by drugs. Non-microsomal enzymes exist in the mitochondria, in the cytoplasm, or in the plasma, and they are less influenced by drugs. What can happen to the drugs? Suppose a drug is active, it will get inactivated, that's one. Secondly, an active drug can form another active substance getting converted into an active metabolite, or sometimes you give a pro-drug, means an inactive drug, and that gets converted into active substance. Let's have an example of active drug getting converted into active metabolite. There are many examples here on this slide. You can go through the slide and study them. I'll mention about one substance from this. Is called diazepam, which is a sedative hypnotic and has got a very long half-life of about 60 to 100 hours. What's the reason of this long half-life? Diazepam gets converted into disethyl diazepam, which is active, which carries out the same action as diazepam. Then gets converted into dismethyl diazepam. This also carries out the same action as diazepam. Then gets converted into oxazepam. That's also active, having the same action as diazepam. So I hope you realize when a drug gets converted into more and more active metabolites, the drug is likely to have a long duration of action. The second group of drugs, types of drugs, are pro-drugs. Pro is someone who stands for, someone who represents. Pro-drug is the drug which stands for the original substance, but it is inactive. And after going inside the body, the pro-drug gets converted into active form. There are many examples here. You are well conversant with the example. Levodopa is a pro-drug, crosses the blood-brain barrier, gets converted into dopamine, and this is how it is useful to treat Parkinson. Dipiveprin, mentioned on this particular slide, gets converted into epinephrine and is useful as eye drops in the management of glaucoma. Next we go to the reactions in biotransformation. There are phase 1 reactions and phase 2 reactions. The phase 1 reactions are generally oxidation, reduction and hydrolysis, and they are supposed to be non-synthetic reaction because nothing new is formed. Whereas phase 2 are called synthetic reactions, and these are usually conjugation reactions with covalent attachment, and because one more substance is formed at the end, they are called synthetic reactions. The non-synthetic phase 1 reactions can be cytochrome P450 dependent or cytochrome P450 independent. The cytochrome P450 dependent reactions as well as the independent reactions are shown on this particular slide. You have ample of time to study this particular slide. I'll make a mention of one cytochrome P450 independent reaction, and that's dehydrogenation. It is remarkable because it's about methyl and ethyl alcohols. And you got to remember, alcohols at the most 25% goes for microsomal enzyme system, but most of it, that is 75% of the breakdown of alcohols, is done by cytochrome P450 independent, that is a non-microsomal enzyme system. The next reaction is reduction, where you add hydrogen or remove oxygen. Warfarin, halothane are the drugs which can get broken down by this way. The next one is hydrolysis, where there is breakdown or cleavage with addition of water, and most of the esters, amides and peptides, they get broken down by this particular mechanism. Cyclization and decyclization are two more reactions which can be called non-synthetic reaction. Let's come to phase 2. Those are the synthetic reactions. In this, a very important one is the first one, that's called glucuronide conjugation. And I would like to highlight the first drug from this, that's called chloramphenicol. And this particular drug is almost outdated now, because chloramphenicol, when given to the infants, when given to the children, because the children do not have adequately developed liver, the conjugation can be in problem, and the chloramphenicol accumulates to produce a very popularly known syndrome called grey baby syndrome. The second one is acetylation, and the drugs which get metabolized by acetylation are isoniazid or INH, hydrolysine, dapsone, procainamide and sulfonamides. There's a very important issue about acetylation is some of us are fast acetylators and some of us are slow acetylators. So if we are metabolizing these drugs slowly, these drugs are going to accumulate and they are going to produce toxicity. Epinephrine, norepinephrine and most of the amines get broken down by methylation. And the other methods of conjugation are sulfate conjugation, glycine conjugation and glutathione conjugation. We come to some interesting genetic factors pertaining to drug metabolism. You know succinylcholine, which is a muscle relaxant commonly used for endotracheal intubation. This is supposed to get broken down by an enzyme called pseudocholinesterase or butyrylcholine esterase. But some persons, some patients can have this enzyme atypical. So it's not able to work like a normal enzyme. So what happens is the succinylcholine doesn't get properly broken down or the breakdown is very slow. And if the breakdown is very slow, this succinylcholine is going to accumulate and going to produce an excess effect. That's excess skeletal muscle relaxation. That's neuromuscular paralysis. And because the diaphragm is paralyzed, the respiratory muscles are paralyzed, you would get apnea. And these patients have atypical plasma pseudocholinesterase. Naturally, you'll have to supply pseudocholinesterase, which cannot be done. The best way to do is to give fresh blood transfusion to this patient, which is going to supply the pseudocholinesterase from the plasma and artificial respiration. Just now I mentioned about acetylation, slow acetylators and fast acetylators. Just to underscore these drugs again, there is INH, procainamide and hydrolysine. Slow acetylators will break down these drugs slowly and they will accumulate to produce toxic responses in the form of lupus erythematosus. This happens in about 50% of whites and African Americans in United States. So that's regarding the genetic factors pertaining to metabolism. There is a very interesting way of breakdown of drugs, and that's typically called Hoffman elimination. What is this? This does not need enzyme. The drug is just broken down. How is it broken down? We don't know. The molecules in the drug spontaneously get rearranged in such a way that the drug becomes inactive. Spontaneous molecular rearrangement without an enzyme. And we have two concrete examples for this. One is atracurium and the second one is cis-atracurium. What's the relevance of this? These drugs are getting broken down without an enzyme. So even if your liver is not working and liver is not supplying the enzyme, the breakdown of the drug is not going to get affected. So especially if the patient suffers from hepatic disease or renal disease or the neonates or the old age patients who do not have adequately developed liver, there's no problem about atracurium and cis-atracurium. They are likely to ask you what are the drugs broken down by Hoffman elimination. Please don't forget atracurium and cis-atracurium. Now let us discuss what is enzyme induction. Induction of the microsomal enzyme system, CYP 450 enzyme system. There are some drugs which are called inducers. If you give these drugs to the patient for a long period of time, they have got a capacity to induce, means to increase the number of metabolizing systems, number of metabolizing enzymes which are going to break down other drugs. So if you are giving inducers for a long time, they are going to increase the metabolism of other drugs, and the effect of these other drugs is going to decrease. Look at the list of inducers, very important: barbiturates, carbamazepine, and phenytoin. You also have rifampin in this group. You have ethanol, that's ethyl alcohol, and graciofulvine. Let's have an example. A 23-year-old woman on oral contraceptive pills is placed on a barbiturate medication for the complaint of disturbed sleep. What is likely to happen? What is likely to happen is she was receiving oral contraceptive pills and now she is added with barbiturate medication. If she continues this barbiturate medication for a long period of time, barbiturates are inducers and they are going to increase the metabolism of oral contraceptives. So the oral contraceptive will get metabolized fast and it will not achieve its required blood level to produce contraceptive effect. This woman is likely to become pregnant in spite of taking the oral contraceptive pill. This is a wonderful drug interaction. And this is why when the woman is receiving oral contraceptives, she is not supposed to take the barbiturate medication. She is not supposed to take any other inducer medication. The next implication could be a drug will induce its own metabolism, that's called self-induction, and decrease its own effect, leading to tolerance over a long period of time. The third implication is the barbiturates again can induce the enzyme system, leading to increased porphyrins, leading to precipitation of acute intermittent porphyria, which could be a harmful interaction. Whereas the same barbiturates could be useful in a patient with kernicterus. These barbiturates are going to induce the gluconide conjugation of bilirubin, and these will be useful in the management of kernicterus.